All right. Good morning, everyone. We appreciate you all joining us this morning for the Austin Ryan White Clinical Quality Management Committee meeting. And we'll start out very briefly by going through the meeting purpose. And this meeting purpose is to improve the quality of care and health outcomes for people with HIV by implementing clinical quality management strategies using logistical, systematic, and effective processes to solve problems in service delivery and clinical care. Just so that we all know, everybody here is from the Ryan White subrecipients, our HRAU staff. We also may have some people with HIV who are receiving Ryan White services joining us today as well. Then, of course, our team Collaborative Research. Today's facilitators will be Jennifer LeBlanc from the HRAU team, Ken Martin from the HRAU team, myself, Thomas Rodriguez-Shucker from Collaborative Research, and my colleague, Michael Coran. And no further ado, we'll turn it over to Ken to do welcome and introductions. Ken, you're on, sir.
Help if I unmute myself. Thank you.
You're welcome.
Thank you all for being here today. Please, let's go around, introduce ourselves, and say our name, agency, and our role there. And if you want to throw in a fun fact about yourself that we might not know, that'd be great too. So I'm Ken Martin. I'm the Grants Program Manager for the HIV Resources Administration Unit. And let's see. Fun fact about me that you may not know is that I live on a farm. And we have right now bees and chickens and a sorry old mule and several dogs. And I will kick it over to Jennifer LeBlanc. You're muted.
Thank you. It would help if I unmuted myself too. Thanks, Ken. Hi, everyone, and good morning. My name is Jennifer LeBlanc, and I am the CQM Program Coordinator at the HIV Resource Administration Unit. Fun fact about me, I'm a huge basketball fan. Go Lakers, no judgment. And I will pass it on to Raju.
Hello, good morning, everybody. My name is Raju Gimire. I am a research analyst in HIV Resource Administration Unit. I started last month, the month before April 11th in the unit. And right now I'm looking at all the data reporting for the grant programs like EHE, Part A, and other grant programs from the unit. So talking about fun fact to me, I'm a big fan of cricket. I'm sure the cricket is not very famous in the United States, but yeah, I like cricket very much. Also, I want to watch sometimes basketball and soccer, of course. I am pretty new to Austin area. I moved to Austin last October, so it's less than 1 year. I moved here from Seattle, Washington. I worked there before I joined Austin Public Health. I hope this is all to say for today. Thank you. I pass it over to Julia. You are muted, Julia.
Every time. I'm Julia, and I'm the HAPA Grants Coordinator here at Austin Public Health with the HIV Resources Admin Unit. A fun fact about me, I have 7 brothers and sisters.
Justin. Is Justin? Yeah.
Good morning, Justin Farrell, Program Manager for the HIV Resources Administration Unit. I started with the unit February of last year, so with the group a little over a year now. Fun fact about me, I have a 2-year-old daughter who keeps us busy and on our toes, and I'm expecting a son July 22nd. So that should be definitely fun, but kind of terrifying at the same time.
Oh, they're cute until they're like 8 or 9, so you're good.
Yeah. All right, I'll pass it to Kim.
Good morning, everybody. Kim Nguyen, also from the same unit, HRAU. I am the EHE Grants Coordinator. Fun fact about me, I love traveling, and I once did the whole 50 states in the US in 3.5 years.
Sandra, why don't you go next?
Sure. I am Sandra Chavez. I'm the Director of Outreach here at Ashwell. Fun fact about me would be I was part of a dragon boat racing team about 4 years ago, but tons of fun, great core workout, and it was a lot of fun here in Austin, actually. So let's see, I'll pick Stacy.
Good morning, Stacy Martinez, Program Coordinator at Community Action. Fun fact about me, in October, I just completed 20 years with Community Action and in HIV care, so. And I will pass it to Christy.
My name is Christy Hanley. I'm the Program Manager here with the Part B Administrative Agency in Bryan. So I'm not in Austin, I'm in Bryan. Fun fact about me, June 20th, I will also, it's my 20-year work anniversary, but also I'm adopting a kitten tomorrow. So my cat is gonna be really mad at me and he'll get over it. I'll pass it to Danny Cedillo.
Thanks, Christy. Danny Cedillo, Community Care, the David Powell Clinic, Data Quality Management Specialist. I guess a fun fact for me as well is in July, it will be my 21st year in HIV care. So it's been fun. I will pick Dr. Haroon.
Good morning. My name is Chandrea Haroon. I'm the Senior Practice Administrator for David Powell. Fun fact about me, I love flying drones. And I will pick Yahira to go next.
Thanks, Dr. Haroon. Hi, everyone. Yahira Saldivar here, Grants Manager at Community Care. I work closely with Dr. Haroon and Danny. And fun fact about me, I also love to travel like Kim. I'm going to need that 50-state itinerary. My favorite solo trip has been 2 weeks across Morocco, so that's very fun. And I'll pick Astrid.
Hi, I'm Astrid Edison with Ace Healthcare Foundation. I'm the contract manager. And a fun fact about me, I have 4 dogs and it's always crazy in the house. And I'm not sure who's next. Danny?
Danny's already gone. This is Brenna Tucker from Community Care as well, David Powell Clinic. I'm here at the Kramer Administration Office. I'm a compliance specialist, and a lot of my compliance role has to do with making sure that we are meeting our grant requirements. Fun fact about me is that I was a music major for my bachelor's degree, and I play in a polka group at the Wahlberg Beer Garden during October and Springfest. And let's see if I could see anybody who is not gone. Maybe Emily Johnston.
Hey, I'm Emily Johnston with the CARE program, and Alita is here with me as well. Fun facts, I used to also play an instrument. I played the violin all through junior high, high school, and college. And I once in a while will pick it up now, but not like I used to. Do you want to say any fun facts about yourself?
Fun facts?
Yeah.
I don't know. I like to watch movies.
There you go.
Me too.
Oh, let's see. We're supposed to pick somebody else. Who hasn't gone yet? Because we joined a tiny bit late. Emily?
I think Todd, maybe.
The other Emily, I see is raising her. Yeah.
It's okay if I go really quick. Yeah, my computer's actually going to do a mandatory reboot in a second, so I need to. My name is Emily Posey. I'm the operations coordinator at Waterloo Counseling Center. Fun fact about me, I guess I like doing weird sports. I play a sport called kayak polo.
I believe Todd Logan, maybe.
Hi, boys and girls. Todd Logan here with Project Transitions, Grants and Special Projects. A fun, actually embarrassing fact is that I competed and was a disco dance instructor in 1978. There you go. Dr. Mike, is that someone to go? I can't.
Yeah, Dr. Mike, next.
Hey, good to be with y'all this morning. For those of y'all who I don't know, Mike Stefanovich here, Associate Director for our Sexual Health Programs here at Community Care. As far as fun facts for me, pretty much I hobbies, one of which includes fishing. And so that's what I intend to do this summer once the temp dips below 100, which may or may not be ever. So good to be with y'all.
I think Astrid?
I
Did you go?
already went, yes.
Okay. Adam.
Hi, I just joined the meeting. We're just doing introductions and was it fun facts or?
Can't hear you, Adam.
Oh, sorry. You still can't hear me?
I can hear you now.
Okay. My name is Adam Carlson. I'm the Director of Quality Management for Vivant Health. I work with the Vivant Health Austin location, but I'm stationed in Milwaukee.
Great, thanks y'all. Is there anybody who has not gone? All right. Thomas, would you mind putting the agenda back up on?
Yes, sir. There we go.
Great. Jennifer, take it away on the data, Part A data.
Certainly.
Our data.
Thanks, Ken. So I am going to share my screen with everyone. And today I'm going to do kind of an overview of some prevalence data over the past few years, continuum of care, and allocations, just so we could take a look at that. Give me 1 second while I pull up the presentation. And let me see if you guys could see that.
Yes, ma'am.
All right, wonderful. Okay. So for trends, this data was pulled from 2011 to 2022 for the Austin HSDA. And as you could see, year by year, there has been a steady increase from about 200 to 300 people living with HIV in the Austin HSDA area, mainly male, some Age groups, age groups, we saw a definite increase in prevalence between the ages of 25 to 34, and also increase between the ages of 55 to 64. By race, increases
Join the meeting.
in the Black and Latinx communities, jumping about 1,000 individuals in the Latinx community from 2011 to 2020, and about approximately 500 between 2011, 2022. Mode of transmission, definitely an increase with MSM and also with IDU. Statewide populations, of course, we see an increase with our Latinx MSM, Black MSM, and some with transgendered. For our continuum of care, the data that I pulled was from years 2017 through 19. And as you could see, we have stayed pretty much in the same range for years 2017 through 19, with an increase of about approximately 500 from 17 to 19. Linkage to care. In 2017, we saw our linkage to care approximately 68% of individuals were linked to care, which increased to 83, almost 84 in 2019. Receipt of care, 2017 to 19, approximately 85% of individuals received care for HIV. Retained in care, statistically, we've averaged around 63.8% between years 2017 to 2019. Viral suppression rates from 2017, 18, and 19 stayed approximately 88%. 2018, we saw 86.5%, 19, 89.5%. So some of our performance outcomes by service category that we saw, this data was pulled for 2020 for LPAP, percentage of patients receiving prescribed ART was at, the target was at 89%. The goal was met by 99.1%. So the average for 8 years, 2018-19 was 98%. For those that were virally suppressed, we saw outcome goal of 87%. Total actual outcome was 84. For EIS, the percentage was at 100% for individuals who received a routine medical care visit within 1 month of diagnosis, and percentage of persons of out of care persons who attended a routine medical visit within 3 months was also at 100%. Health insurance premium and share cost assistance, the percentage there was 90.6%, which was right on target. Medical case management, including treatment adherence, the goal was 85. We saw the actual outcome being at 91.5. Percentage of clients who were virally suppressed was at 73.8%. For medical nutrition therapy, the goal was 85, and the outcome for that measured year was 86. Mental health services, the percentage was 85, goal met, outcome was 85.3 for 1 medical visit in each 6-month period of the 12-month measured year, with a minimum of 60 days between medical visits. Percentage of clients were virally suppressed was at 87.7%. Oral health care percentage that was met that year was 89.9%. And for patients who had a dental treatment plan that was updated at least once in the measured year, the goal was 95%. Actual met goal was 91.6. And who received oral education at least once in the measured year, the goal was 95.8. Percentage of HIV oral health patients who had a periodontal screening or exam, the goal was 92. And the outcome for that year was 81.6. In addition, percentage of HIV infected oral health patients with a phase 1 treatment plan within 12 months of establishing treatment plan was at 62.4, with the goal being 75%. For outpatient ambulatory health services, the individuals who were prescribed art therapy, the goal was 98. It was met at 99.1%. Percentage of patients aged 6 weeks or older who were prescribed PCP, the goal is 92. Net goal was 97.2. And for those who received at least one medical visit each 6 months of the 24-month measured period for a minimum of 60 days between medical visits, the goal was 85%. Net goal was 64.7. Percentage of patients who were virally suppressed, the goal was 87, and for 2020, met goal was 84%. Substance use disorder outpatient care, percentage of clients who had at least one medical visit, goal was 80%, net goal was 89.8%. And for those who were virally suppressed, the goal was 75%, net goal was 77.6%. For emergency financial assistance, who were prescribed ARP, that goal met was 99.1. And for those who were virally suppressed, it was 84%. Food bank home delivered meals, viral suppression rate was 85.6. For housing, the goal for individuals to have one medical visit in a 6-month period of the 12 months of the measured year was at 100%. And percentage of viral suppression was 84.6. And percentage who received overall satisfaction, 94.4%. Goal was 95. Medical transportation, for those who had a medical visit, it was net goal was 89%. Non-medical case management percentage who were virally suppressed was 76.8%. Substance use disorder residential services who completed a 30-day was at 10%, but we also had only one provider during that year, I believe, stopped taking clients. Ryan White Part A. Percentage of substance use disorder residential clients who had a medical visit within 6 months of the 12-month measured year was at 100%, and 60% were virally suppressed. For MAI, percentage of clients who were virally suppressed for 2020 was 72% out of outcome target of 85. For our Black clients, for our Latinx clients. The actual outcome for 2020 was 86.2 for non-medical case management for both of those. For early intervention services for Black MSM was at 100% for attending a medical visit within 1 month of diagnosis, and 100% for having a routine HIV medical visit within 3 months of care. And for the Latinx population, for MAI, 100% was met within 1 month of diagnosis, and 100% within 3 months of initial encounter. I'm also going to share with you a little higher level data for allocations. 1 second. I pulled that up. I can't see the bar up there. Okay. Okay. So this one goes over the allocations per service category for Ryan White Part A MAI. And these are for grant years 2017 through 2021. And as you can see, the reason for showing this is because there has been, of course, reasonable increases in cost per client, and gives you an opportunity to kind of take a look at what data you might need collectively within your agency for your own quality improvement projects and what that might look like for you. So for the AIDS Pharmaceutical Assistance Program, as you can see, the allocations decreased and the amount of clients, the cost per client increased from 277 to 426 from 2017 to 21. So the unit prescription cost decreased, but the cost per unit increased. And there's some graphs about that. Some notable observations. There was, of course, a greater need for LPAP with budget cuts in ADAP in 2021. And pharmaceutical needs and purchases, they vary from year to year. Medication assistance is ranked number 2 for people living with HIV who needs this service. Early intervention services from 2018 to 21, the cost per unit has increased, especially in 2020, especially impacted by COVID. And the allocation is split between non-medical case management, definitely impacted by COVID, and service category is just hard to track clients as they're only counted when they enter the program, and the provider may have a large number of encounters before one becomes a client. Early intervention services, again, 2017 to 2021. There was a decrease in the amount of clients served between 2018 to 2020, but the cost per client steadily increased from 2020 and 2021. So in 2021, the target special populations of Black MSM and Latinx MSM, Black women and transgendered, and $2,512 was added in carryover. Peer support was identified as a gap and key informant interviews and focus groups, both peer navigation and peer support groups. And this one is for HIPSCA, as you see from 2017 to 2021. Cost per client definitely increased, as well as the number of clients receiving services in this area. Notable observations: increasing premium amounts, Affordable Care Act considerations. More than 50% of clients had medical premiums for ACA paid. Each year, the number of clients moving to ACA goes up. 90% of services in 2020 paid insurance premiums, 4% for medication copay, and 6% paid for medical services. 26,000 was reallocated to HIPSCA. Medical case management for the grant years 2017 through 2021. Steady increase in the amount of clients seen in the service category. There was a decrease in the cost per client and decrease in the cost per unit from 2020 to 2021. Notable observations: Austin funds very little medical case management. Only 5% of clients receive it, and 22% receive non-medical case management. Nationally, many jurisdictions provide case management to a majority of clients and often fund more medical than non-medical case management. Client numbers were not affected, but fewer units due to telehealth, as most service categories were impacted one way or another for COVID. And medical nutrition therapy from 17 to 2021. Cost per client actually decreased in 2021 and saw a slight decrease in units from 2020 with an increase in 2021. Decrease in cost. It seems that 2021 cost per unit was highest in that year. And of course, a large drop in counseling in 2020. Let's see here. Mental health services from 2017 to 2021, with a slight decrease in clients from 2020 to 2021 and an increase in cost per client. Providers have identified mental health as a key need for many clients as they cope with isolation and additional problems associated with COVID-19. 3 out of 5 people living with HIV indicated a current diagnosis for mental health condition. Oral health services from 2017 to 2021. 2021, definite increase in the amount of clients served, with a lower cost per unit. And of course, they were impacted by COVID and were opened at reduced capacity for safety during that time. Notable observations for this: where people come in, they're more focused on immediate needs, such as food, transportation, and housing. And when people came in, not a lot came in asking for dental care. In addition, outpatient ambulatory health services, cost per client has increased definitely between years 2020 and 2021, with a small decrease in 2021 for the amount of clients served. So the outcomes for clients receiving care for viral suppression, the goal was 87%, and the MET goal for that year was 88.2. So some notable observations: interplay with Affordable Care Act. And of course, client was closed due to COVID and reopened at reduced capacity. This is the number one, and people living with HIV need this service. Ryan White Part A for substance use services. Cost per unit in 2020 was at $2,118 per client, and cost per unit was $355 at the highest. And here's a small graph showing the percentage of clients in areas who reported HIV exposure was at 3,627. And notable observations: COVID affected the service area for not being able to meet in groups. Office of Support, notable observations: substance use is a needed service, but only one place to go in Austin. Key informants recommend to co-locate this with other services. Emergency financial assistance. From 2017 to 2021. In 2017, 247 clients were seen. In 2021, 150 costs per client, 683, and cost per unit continues to go up. And it was used for bridge medications while awaiting ADAP and connection to rapid linkage. Other services could be funded with a service category if additional funds are added. And medication assistance ranked number 2 in the year 1 needs assessment summary. Food bank home delivered meals from 2017 to 2021. Number of clients continues to increase, as well as the cost per client. Notable observation, of course, is a basic need and other community resources, and ranked number 5 in the year 1 needs assessment summary. Housing services from 2017 to 2021. Number of clients relatively the same. Of course, we see the cost per client go up, and the cost per unit goes up as well as many of the other categories. Notable observations: upcoming housing and currently underfunded status for recuperative and palliative care. 3 out of 5 indicated needing help with housing in the past 12 months. Housing is a main priority that merged with focus groups and key informant information for year 2 needs assessment focus groups. Medical transportation services. From 2017 to 2021, the allocation definitely increased between those years. And as you see, the amount of clients has nearly doubled. Cost per client went down in 2021, but the need is still really great. COVID had an effect. Less transportation was needed. There was an increase in telehealth. So during that time, travel was in low demand. Notable observations from Office of Support: pilot share ride program in Austin TGA. And it was number 6 in number of people living with HIV who need the service. 1 in 3 people living with HIV indicated that their transportation situation made it difficult to access HIV services. Is a key barrier to accessing these services, and expressed that transportation passes can be difficult to obtain. For non-medical case management from 2017 to 2021, again, a huge jump in the amount of clients receiving the service starting in 2017, where 156 clients received the service. In 2021, that was at 489. Cost per unit went down, more clients seen. Notable observations from the Office of Support, Directive and Funding to provide peer navigators for newly diagnosed individuals. Potential service categories could be non-medical case management and EIS. Peer support, it has been identified as a gap in both informant interviews and focus groups. And non-medical case management from 2017 to 2021 began with 164 clients being seen in 2017, 238 in 2021, with the cost per client starting at 822, where it's gone up to 1,164 per client in 2021. In 2021, a new requirement was to target special populations of Black MSM, Latinx MSM, and Black women and transgendered. Office of Support, notable observation, MAI program funds should address a gap in the linguistic and culturally competent services for the Latinx Hispanic populations. And case management ranked number 4 in number of people living with HIV who needs this service. And again, peer support identified as a gap. Peer support in the form of navigators has been identified as a way to link to care for newly diagnosed people with HIV and to support retention and engagement. And retention and care is an issue specifically for young Black women, Latinx, MSM, Black MSM, and those who are experiencing insecure housing. Residential substance abuse services. Again, in 2017, it began with 13 clients. In 2021, that went to 4, and cost per client has stayed between 9,000 in 2017, and 2021, it was at 7,625, with the cost per unit increasing. Let's see here. And so notable observations, balance of funding between residential and outpatient, 50,000 reallocation, and a subcontractor closed to Ryan White clients in April 21. New subcontractor signed in the fall, which may impact the number of clients that we're seeing in 2021. So this was the grant and budget summary. This has years 2016 to 2021 for all total service units and unduplicated clients served. Definitely an increase from 2016, where 1,934 clients were seen or served, to 2021, where 4,787 unduplicated clients received services through Ryan White Part A. Ryan White MAI, in 2016, 150 clients, unduplicated clients were served. In 2021, we continue to see that increase each year to 263. Both combined, Part A and MAI, unduplicated clients were relatively the same, but we did see an increase in total units, service units, and an increase in expenditures each year. And so this is some of just the demographic information that was also provided in the slide deck of individuals with HIV in Austin TGA for Ryan White Part A and MAI. again, a large increase or in the age groups between 25 to 64. Let's see here. Yeah, and so that is the information for the grant years between 2016 to 21 and the allocations. So with this, you could potentially look at who is who is highly utilizing the services within your agency, and how can we incorporate that into your quality management projects. And again, going back to the data, I know this is combined with all agency subrecipients, but what data information would you need for your own agency to incorporate into your quality management projects? Does anyone have any questions?
Jennifer, I think you've given us a lot to digest, and I really appreciate having this huge overview of our data in this area. I think, you know, in future meetings, I want to let you know that we'll drill down to some of these and really spend some time on the data and how it relates to your individual CQM projects. But yeah, does anybody have any questions or observations about the data that was presented?
Jennifer, that's amazing. That was a really good in-depth overview of all of that's a lot of information, great information. I do realize it's out of Aries. And so I have, it's like, we don't have Aries anymore. And it is like you show right there, that gives us an overview of what's happening in the community without a really good database or something to rely on. You can't rely on your data, and so I was kind of curious as to what we were seeing or what we were thinking about going forward. How do we compare what we found in Aries to what we're doing now? Do we align them? Do we not? I mean, I think we're going to have to, right? Because it's all pretty much the same information that we all want to know. Do y'all have any thoughts as to like what we do now?
So Jennifer, I'll jump in real fast. So Sandra, you bring up a really great point. And I've also run into this with other jurisdictions as well, where they've either started crossing over platforms or going away from another type, like Aries to TCT, particularly like in New Jersey, they've been moving across Careware and another system. And what we've been doing in that clinical quality management program is, like Jennifer said earlier, we'll start working with Raju to really hone in on what each specific agency needs. And then who knows the data better than yourself? So, as we start presenting that data at the individual level, you can just chirp right up and say, hey, that's not right. So for instance, like, in one jurisdiction, we came back with certain agencies having viral suppression rates at 34%. They're like, there's no way. We calculate this manually, we're at 87. So I think it will give us an opportunity to also address, like you said, data issues and continuity of that data across multiple platforms. I've also worked with, Aries and other jurisdictions within Texas, and no, it is not the most reliable data platform. So we get that. And it may be an opportunity for us to do kind of a high level look into certain performance measures that you may be picking as a quality improvement project to say, you know what, we're going to do this one manually to see if the data matches. So maybe we baseline one of your projects manually, and then we compare that to the data to see where the inconsistencies are. That's just my thought, and I'll turn it back over to HRIU to see what they think.
Yeah, Sandra, I hear you. I believe I understand. We're totally frustrated also with the quality of the data that we're able to get out of Legacy, Aries, and the new TCT. We're going to be talking with y'all in the future about some plans that we might have, but I think this is probably not the time to do that right now. But appreciate the question and want to reassure you that we're on it, and we'll be talking with y'all to gather your thoughts on the matter as we move forward.
I understand, absolutely. And I think, you know, to Thomas's point about collecting manually, and then we can use it to compare at a later date is probably a good idea. And it would help us create a baseline. I don't know if we ever even had done that with Aries, and it wasn't meant to be more of a complaint. It's just so that we're not losing anything while we're moving forward.
I will say one thing, lessons learned from when I was in the homeless field and we started transferring everything into homeless management information system.
I do remember that.
Yeah, we really urged people to keep manual databases during the first year of that because we were unsure about the data quality. So that I think it's a good idea for you to keep information on your own databases or manually, especially since we're still in the first year of TCT.
Makes some sense. Thank you.
Any other observations, questions about the data?
Hi, this is Justin. I just want to add one thing that I'm sure you already know, but as far as the data is concerned, it's only as good as the information and data that you all input into the system. And, you know, notwithstanding the current issues with TCT, if you are having issues entering, you know, viral loads for clients or any other information, please reach out to us so that we can get it entered and resolved so that we do have accurate data. I know recently there have been a couple of agencies who had issues entering data, so just wanted to throw that out there as well.
And I'll just say, ultimately, the responsibility for keeping up with your numbers is your agencies. And we're going to ask for your numbers regardless of whether they come from TCT or from your own database. So, but we're also going to work on solving this problem for a better solution for everyone. Any other comments, questions? If not, we'll turn it over to Michael Coran, and he'll lead us through the policy clarification notice 1502. Take it away, Mikey.
All righty. Howdy, everyone. Thomas, are you gonna? Okay, I have the PowerPoint up ready to go too. Okay, thank you, sir. All right, I'm going to talk to you about policy clarification 1502, which is focused on clinical quality management. The purpose of the policy clarification notice is to clarify the HRSA Ryan White HIV and AIDS program expectations for clinical quality management. Ryan White HIV and AIDS programs are required to establish a CQM program to assess the extent of which HIV health services provided to patients under the grant are consistent with the most recent public health service guidelines, otherwise known as the HHS guidelines, for the treatment of HIV disease and related opportunistic infections, and develop strategies for ensuring that such services are consistent with the guidelines for improvement in the access to and quality of HIV services. What are the components of a CQM program? A CQM program is the coordination of activities aimed at improving patient care, health outcomes, and patient satisfaction. To be effective, a CQM program requires infrastructure, so the staff, resources, and conceptual outline of the CQM program, performance measurement, the data that will drive the improvement activities, quality improvement, activities undertaken in response to the performance data findings. CQM activities should be continuous and fit within and support should be continuous and fit within the support framework of grant functions. Recipients are strongly encouraged to use the National HIV/AIDS Strategy, or the NHAS from 2020, to frame CQM activities and goals. Boop, boop, boop. Okay, we have a quick little true and false question, which is basically a yes, no, not a true false. But a CQM program is doing really well with health outcomes, like viral suppression. The TGA is at a 90% viral suppression rate. Is the CQM program still needed? What do we say here? Let's see. I'm looking for faces to approve or shoot that down. I see Christy shaking her head yes. Emily shaking her head yes. Ken, Sandra, everyone else doesn't have their photos up. So Thomas, what do we say? It is true. Yes, a CQM program is still required. According to the Title 26 of the PHS Act, Ryan White HIV and AIDS programs, Parts A through D are required to establish a CQM program that includes activities at the recipient agency and all funded subrecipient organizations. Infrastructure. Appropriate and sufficient infrastructure is needed to make the CQM program successful and sustainable. Infrastructure is needed to plan, implement, and evaluate CQM program activities. Ryan White HIV and AIDS program grant funds can be used to establish an appropriate infrastructure for a CQM program. An ideal infrastructure consists of leadership to guide, endorse, support, and champion the CQM program, a CQM committee that develops the CQM program and corresponding activities, dedicated resources and funding that is adequate for CQM infrastructure and activities. CQM costs include training and capacity building, membership dues for CQM related professional organizations, quality related certification, recertification, and continuing education. Also, it includes the cost to implement CQM activities, i.e. collecting performance measurement data. It also requires a clinical quality management plan that describes all aspects of the CQM program, including infrastructure, priorities, performance measures, quality improvement activities, and an action plan with a timeline and responsible parties. Also, evaluation of the CQM program. There's a lot of ands in that. Next slide, please. Involvement of people with HIV that reflect the population being served to help ensure that the needs of people with HIV are being addressed by CQM activities. Stakeholder involvement, i.e. subrecipients, other recipients in the region, planning body members, and its committee members that provides input on CQM activities to be undertaken. Last but not least, it requires a plan that evaluates the effectiveness of the CQM program to ensure that the CQM activities are making changes that positively affect the outcomes. Performance measures. Performance measurement is the process of collecting, analyzing, and reporting data regarding patient care, health outcomes on an individual or population level, and patient satisfaction. In order to appropriately assess outcomes, measurement must occur. Measures should be selected that best assess the services the recipient is funding and that reflect local HIV epidemiology and identified needs of people with HIV. Recipients are strongly encouraged to include HRSA HIV and AIDS Bureau measures and the National HIV and AIDS Strategy indicators that align with the national goals to end the HIV epidemic.
So I'll jump in here, Mikey, real fast. And so one of the things that the committee is going to start looking at when we start developing our draft of the clinical quality management plan is really looking at what service categories need specific performance measures. So, you know, as you saw in that data that Jennifer presented earlier, it looks like HRAU and the staff are already tracking at least one indicator for each of the services that you provide. That's not a requirement of HRSA, but it is a good idea to make sure that the services are meeting the needs of our clients, right? So in our plan, we'll specifically align ourselves to what HRSA requires. So we'll identify measures that require a performance measure. And so HRSA has told us in PCN 1502, that if a service category is being utilized by less than 15% of the total clients in the TGA, we don't need a performance measure, right? So you'll see, and this is an example. Sorry, it's a little small, but starting out with early intervention services and going down through there, and it will calculate a percentage for us to say, yep, we need one performance measure, or we might need two performance measures, depending on what number of clients are receiving services. So less than 15%, we don't need a performance measure. 15 to 50%, we need one performance measure. And any service category that's providing services for more than 50% of your clients needs two performance measures. So again, when we start getting to that CQM plan, we'll look at this in a little more detail. Mikey?
Okie dokie. Recipients should identify at least two performance measures for the Ryan White HIV/AIDS program service categories funded by direct Ryan White funds, rebates, and/or program income, where greater than or equal to 50% of the recipient's eligible clients receive at least one unit of service. Recipients should identify at least one performance measure for each Ryan White service categories funded by direct Ryan White funds, rebates, and/or program income, where greater than 15% and fewer than 50% of the recipient's eligible clients receive at least one unit of service. Recipients do not need to identify a performance measure for Ryan White service categories funded by direct Ryan White funds, rebates, and/or program income, where fewer than or equal to 15% of the recipient's eligible clients receive at least one unit of service. So just as Thomas said, so greater than or equal to 50% of the recipient's eligible clients, we need to do more. 15% to 50%, we need to identify at least one performance measure, and then under 15%, we we do not need to identify a performance measure. Recipients should analyze performance measure data to assess the quality of care and health disparities, and use the performance measure data to inform quality improvement activities. Recipients should have an established process to collect and analyze, or collect the numerator, denominator, and percentage of the performance measure data at least quarterly. Another true false question for you. Let me open my screen so I can get as many of your smiling faces into one. There we go. QI projects are required for each funded Ryan White HIV and AIDS program service. True or false?
The tricky one.
Christy, Ken, Sandra, Emily. Okay, next slide, Thomas. False. But all funded services should be assessed through performance measurement to evaluate the effectiveness of the service. If the performance measurement is not meeting expectations, then a QI project to address the service should be implemented.
Right. Keep in mind, if it's less than 15% of clients utilizing the service, then it does not require a performance measure, but we should still track it to make sure that it's meeting expectations.
Recipients should analyze performance and measure data to assess the quality of care and health disparities, and use the performance measure data to inform quality improvement activities. True or false? All righty, I'm seeing some head shaking. Yep, true. Recipients should have an established process to collect and analyze the data at least quarterly. All right, I'm gonna move you guys over here now. Quality improvement. Quality improvement entails the development and implementation of activities to make changes to the program in response to the performance data results. To do this, recipients are required to implement quality improvement activities aimed at improving patient care, health outcomes, and patient satisfaction. Recipients are expected to implement quality improvement activities using a defined approach or methodology, or model for improvement, lean.
So as we move forward and we start developing our quality and management plan, we have already had kind of a small conversation about looking at our first PDSA cycle, like our first official PDSA cycle since our new plan. Some of you may already be doing some quality improvement projects or plan, do, study, acts. So that's a different, different methodologies for doing quality improvement, whether you're using a model for improvement or Sigma 6 or a lean project. we'll do the simple PDSA, Plan, Do, Study, Act, and help each of us to look at a performance measure that we think that we can increase efficiencies or performance ratings as we move through the quality improvement project. And we're looking for that around August, September-ish to kick that off. And we'll run that project for about 6 months, and we'll help everybody start on level playing field. So if this seems like, for some of you who may already be clinical quality management masters, and this might be, just a refresher course for you, but we want to make sure that we're starting everybody out on the same page with an understanding of what clinical quality management is, and start building upon that knowledge as we move forward towards our quality improvement projects, or our PDSAs. And so we'll start looking at that after we develop our clinical quality management plan in the next couple of months. All right, any questions? No, it's a lot of information today. It's like drinking from a fire hose. We will be more than glad to share all of this with you. But for this entire clinical quality management project, we'll definitely, policy clarification notice 1502 will definitely be our guideline as we work through this process. And most importantly, if you're not a data person, we want to make this fun for you, right? And always pick low-hanging fruit that we can feel accomplished. Wake up every morning, you make your bed, you've already accomplished one thing before you've even left the room, right? So we want to kind of make CQM the same way. Let's do little steps so that we can get to ending the HIV epidemic in a couple of years, right? Our goal is 2030, and it's quickly approaching. All right, so our next, where's my, sorry, I've got like 50 million screens open, probably like everybody else. So next, really quickly, I don't have a presentation. I know you'll be thankful for this, for the CQM plan development and next steps. But I will stop sharing so we can see everybody's beautiful face. So for the next couple of meetings, we will be talking and bringing forward to the Clinical Quality Management Committee some draft plans of the CQM plan. So keeping in mind from what we just learned about 1502, there's a couple of different components that we need to make sure that we have addressed in our CQM plan, right? And those three major components are, does anybody remember? Infrastructure, performance measurement, and our quality improvement, right? So we really need to outline who are our partners, who are responsible for specific roles, and then finally, how are we going to improve upon our data? So earlier, Jennifer gave us tons of data to look over. And I would say, if you know your data really well, you'll probably already be able to identify at least one quality improvement project. For those of you who are new, always pick something that HRSA looks at and that we always hear about in HIV field, right? Viral suppression rate, that is a very low hanging fruit. So you'll want to do like a baseline data dive to say, currently my agency's viral suppression rate's at 83%. Let's set the bar. We want to make 85 by the end of the grant year. You're probably saying, oh, 2% is nothing. 2% is a lot, right? When you start thinking about all of the clients that you serve, right? So, that's an easy one. If you're a clinic, I can throw out three that are really easy to do really fast. As we know, when the PDSA cycle is coming around, guess what season it is? It's flu season. So we could very easily look at the immunizations or the flu vaccination, right? From October to March. That's a really easy one. Maybe your influenza vaccination is at 70 or 60%, right? Sometimes that is just documenting a simple declination from a client saying, I don't want it, but you just haven't documented it to give yourself the credit for that, right? There's not a box in the EHR sometimes for you to click to say, client says he doesn't want it, or they don't want it. And so it's not a really easy indicator that pops up with the click of a button, so that maybe a quality improvement project there is, clicking the box and then just writing beside that declined, or clicking the box and saying, got it at Rite Aid, just giving yourself the credit that you at least went through the process of making sure the client has been vaccinated. So there's some really easy things. And we want you to all have buy-in to the plan. So as we draft that, we'll come back to the committee, we'll review certain sections of it in the next couple of meetings. And then that will be a living document throughout the CQM process. So as we have new changes to it, or we need to update some things, we'll do that along the way. And then hopefully data will become your new friend and you'll be excited about the CQM process. We don't want this to be overwhelming. We want you to be excited about it. And after the next couple of meetings, HRAU staff and myself, we will all step back and we're going to start giving the floor to you. We want you to present your project. We want you to talk about the project you're doing, because I bet somebody else in the room would love to steal your project and try it for themselves, right? So that's the whole idea. Let's not reinvent the wheel. Let's listen to what our colleagues are doing. Let's steal shamelessly, and let's see if we can implement that within our own organizations, because I'm pretty sure we all have the same problem with something, right? So that's the fun part about CQM, is not reinventing the wheel, but taking a project, you know, updating it to your organization and making it work for better patient and quality care. And that, I mean, that's my basic spiel of the CQM plan. Made it super easy, and we will continue on. Mr. Ken, I'll give it back to you, sir, for recipient updates. You're on mute. The infamous mute button, I know.
Gets me every time. So Justin, do you want to give any updates that we might have?
The, I guess, biggest or main update is that we received our final notice of award last week. So we'll be updating the contract amounts to reflect that final allocation. Most of you should have been notified that your contracts have been executed. I know there's still a few more outstanding, but look forward to seeing your first claims come in this month. And that's really all I have.
That's great. We also, I believe, still have, well, we have 2 unfilled positions for grant coordinators. I believe those job announcements are still up on the city website. You know of anybody who would be good, or maybe it's closed by now, I'm not sure. But we'll be looking to fill those. I know Justin has had several qualified applicants, resumes come to him, applications come to him. Is there anything from any of the subrecipients that needs updating? Anybody have big news from your agency? All right. Any local events happening in the HIV community that you want anyone to be aware of, or everyone else to be aware of?
I kind of do. I know me and Kim will be presenting this a little bit more in the future, but Jennifer had talked about the peer support and the peer navigation that was seen as a gap. And we're, setting up and the infrastructure and whatnot to start doing that here centralized. So we'll get more to that very, very soon as to like how that will work. We actually would like to hear from providers. So we'll have like an open forum to be able to discuss some of that and how to best support all the other agencies as far as peer support is concerned. Kim, did you have anything you wanted to add to that, or is that?
No, you pretty much cover it. So we're still looking at the schedule and see what time would work best for everybody, and for Ashwell to gather all the data and documents they needed to give a quick presentation, and hopefully that will spark more collaboration in the future.
Yep. Sounds awesome. Thank y'all.
I can, if I could just chime in here real quick. If any agencies have clients who are members of the community who are attending today, if you have anyone who needs to receive their incentives, if you could please email me, Michael at Collaborative Research. I will be able to get that right over to them as soon as possible.
Is that a .org?
.us. It's in the chat.
.us. Okay, great. Thanks for, if I kept up with my chat better. All right, anybody else? Dr. Mike, you came off
Oh yeah, no,
on
thank
video.
you. Yeah, just a quick community item for those of y'all who may or may not have received the email. Rosie Castaneda at Austin Public Health had sent out an email last week, kind of reviving our community STI provider meetings that we had done previously about once every quarter, just as a way to disseminate, and standardize best practices in STI screening treatment across the city. And I think that's this upcoming Wednesday from 12:15 to 12:45. Rosie Castaneda, APH, is a great contact for it, but I'm happy to forward that meeting invite to any of our community-based STI testers or providers. So
Yes, could you do that? That'd be awesome. Thank you.
absolutely.
Thank you, Dr. Mike. Anybody else? Do you want to put your email address in the chat? Did you already do that? No.
We had an update from Vivint Health.
Okay.
We recently moved to an integrated location at 6505 Airport Boulevard. Previously, we were in 3 different locations, so we're now centralizing our services for Vivint Health. And apparently there is a ribbon cutting ceremony this Tuesday evening, and you can reach out to Aubrey if anyone's interested.
Awesome. I'm sure a lot of us will be looking forward to going to that. Any other updates? If not, I'm going to give you some time back.
All right. Well, thank you everybody for joining us today. We appreciate all of the great conversation, and we hope you enjoyed all of the data that we looked at and all of the educational moments today. So we hope you have a great rest of your week and have a great weekend, and we will see you soon.
Thank you.
Thank you.
Thanks a lot.
Thank you.
Thank you.
You.